pathways and cross-sector working within that. I've just been given a nod that recording has started. So if you are someone who is not wanting to be heard or seen in the context of the webinar being recorded, please turn your camera off and remain on mute and use the chat instead. So just to highlight that we will, I'll just go through the housekeeping. No, actually I won't. I'll just to highlight that we're going to focus today on the difference in community exercise provision, and that not all programs available in our communities are evidence-based to prevent falls. Dose, strength progression and balance challenge do matter, and we hope to try and really land that message with you all this evening. And finally, to kind of really, I suppose, drive home the fact that there are differences between recommending someone to a community exercise class and referring someone to an appropriate exercise class that's the right one for them, in order for them to actually achieve the benefits of strength and balance training that meets evidence base and dose, an appropriate challenge for that individual. So welcome, and if this isn't the session that you were expecting to join tonight, please take your leave now. So just to highlight that we had intended on having the opportunity for you to see the referral forms in advance of this evening, but I appreciate they only got sent out today. So whilst I'm just going through the introduction slides, Hannah has put the link to the referral forms, if you haven't already seen them, that are hosted on the AGILE and on the Later Life Training website. She's put the AGILE link on the website, on the chat box now. Hannah, I'm just realizing you probably need to stick the Later Life Training one in too, because if it's closed on the AGILE website, the exercise professionals in the room won't see that. Have a little look at them while I'm going through the introduction slide, please, because we have some questions about the forms in the context of the presentation. I just start off by welcoming Professor John Skelton and Bex Townley today with us, who we enjoy working with immensely in AGILE as a National Executive Committee. Dawn, as you know, is the Director of Later Life Training and a Professor of Aging and Health at Glasgow Caledonian University, and many more accolades with it there on the slide. I'm not going to go through every one. And Bex as well, a Director of Later Life Training and a Senior Activity and Health Practitioner.
Without the accolades, just to say.
Without the accolades. And then obviously my peers, Hannah Barber and Steffi Bailey, who are Agile Falls and One Health officers as well. And in the background, we've got Sarah Lambert, our Education Officer, and Suzanne Arnold, Agile Chair, supporting. Thanks everybody for your time this evening. Just keen to know who we've got in the room. So if you could, we're going to use Menti a few times this evening. So if you've got your phone to hand, or open up a Outlook page on your computers and keep Menti open. And if you could log in and tell us your profession, and Hannah will be able to share back the results with us. So the Menti is www.menti.com, and there's a code there, and the code will change for each question. So be mindful of that when we present further Menti questions later on in the session. How are we looking, Hannah? How many have we got in the room, so we can get a sense of the numbers who've completed the question?
So numbers are still going up, so just give people a chance. We've had about 45 people are doing it, so the numbers are still going up, so I think just give it another second or so, people log on. Okay, let me share these with you now, because it's looking more stable. Okay. So do you want me to share my screen, or do you want me to talk you through the results?
No, if you can share, share.
Sure. Okay, I will do that. So there we go. So very predominantly videos on the course, but a couple of other people as well. So 3 people. We need to know what is something much more exciting. So can you pop that in the chat, those 3 people?
Nice to have you join us, exercise professionals in the room. And as we've been asked before the event, you know, these slides will be made available to everybody after the event. and hopefully we'll be able to make them available to colleagues who aren't able to make it tonight as well.
Occupational therapists are much more exciting.
Fair enough.
That's fair enough. Fair enough. Thank you for that, Susie.
I would agree.
And a falls technician.
Yes, hello, Donna. Good to see you.
So I'll just share my screen again, please. Is that all right?
Yep. You can
And where am I opening up? There we go. Give me a nod that I've got the right slide back up. Yeah.
Yeah.
Thank you. So as I've already talked about the referral forms, hopefully you've got sight of those in the background. You can have a look at those really briefly. Please, everybody's unmuted, but if you do want to speak in the session, you should have the functionality to unmute yourself. We will have questions at the end, but if you have questions that you don't want to forget or lose your train of thought, please pose them in the chat, because we've got Sarah and Steffi picking them up as we go throughout the, don't know what happened there, sorry, throughout the presentation. Please keep your phones on silent, especially if you're remaining off mute. And we don't have breaks built in, so do take your leave for refreshment breaks if you want that. And if you have any problems in the middle of the session, please contact our education officer, Sarah. Sorry, that's my mouse, fidget too excited, via the Agile Education Officer Gmail listed there. So really briefly, the aims of our session tonight are to update on the falls prevention evidence base, a whistle-stop tour, and we'll highlight the indications for different evidence-based falls exercise programs, and also more generic strength and balance training programs that are available in the community. We're going to describe the difference between Otago leaders and FaME postural stability instructors. We'll give you the rationale from both later life and Agile's perspective on the need for high quality information sharing to follow an individual through their falls prevention pathway, specifically in relation to their exercise prescription at baseline and throughout the rest of their pathway as they transition. How we can overcome barriers to optimize the outcomes for people who are at risk of falling or who have fallen, and highlight some resources to support you in your local falls prevention services and place-based systems to support individuals achieving dose and seamless falls prevention exercise pathways. And finally, a call to action for exercise professionals, both physios and those who are affiliated with later life training, to, I suppose, act on the recommendations of tonight's presentation. So this work comes on the back of continued collaboration between Agile, BASIS and later life training. It was 2019, we put out a shared purpose statement, which was to highlight that we would work together to optimize partnership working between physios and exercise professionals across exercise pathways. And at that time, our aim was to drill down and shine the light on how we would achieve this partnership work in a more optimal way, with shining the light on the falls prevention pathway, so that we could achieve sufficiently dosed exercise for falls prevention. What we promised at that time was that we would ensure a clearer understanding of the training of exercise professionals, and we hope to revisit that tonight. Define the scope of practice and responsibilities of exercise professionals, show what evidence-based exercise programs should look like, give clarity about who goes when and where and when, and that really does matter. And as I've alluded to already, differentiate between the difference between referring someone to a community exercise program and recommending exercise programs to someone when they finish their NHS delivered exercise for strength and balance training, and also to support you as those who are providing these services in our communities to support ongoing service improvement. Before we move into the meaty bits, when you've had a chance to look, at the referral forms now, I hope, we'd like you to share with us your thoughts as you look at those referral forms. What comes to mind? The three words, the first things that pop into your head when you open them up, be it the short form, the long form, and be that from the perspective of an exercise professional, or as a physiotherapist and an occupational therapist in the room. If you work in falls prevention services and this is of relevance to you, we're keen to hear your views as well. So the Menti code to use is 22905717. How are we looking, Hannah? You're on mute.
Yeah, sorry. I had to go back from screen to screens. We're about 10 at the moment, so I think, yeah, it's starting to pick up a little bit now, so just give it another minute or so, I think. Let's see. Right. There we go. We've got about 30 people now. So there's quite a few words come up. So let me share my screen again.
People continue to add after we've shared. We can pull them.
Yeah, and I can access it
final answer
afterwards,
into
and I
the
can.
slide deck before we share it.
Yeah, exactly. We can share the final one. So there we go. That's what we're at the moment.
Okay, so I've just moved Bex out of the way so I can see. We've got comprehensive, detailed in there. So jumping out at me that the language is more asset focused and positive. But we've got some others down there, long and unaware. So comprehensive, detailed, clear and informative. Vital, it's nice to see that. Let you stop and sharing,
sorry.
Hannah.
That's
All right.
there you go. Sorry. I was seeing if I could see the other results and forgot I was sharing my screen.
Extensive, long version, long. Similar to ours, was suggesting that some people might already using referral forms. That's exciting. Unfamiliar, usable. I thought that said unusable for a minute. Trust building. It's really, really good to see. Succinct, common sense. Okay, we might have an easier argument to point to get across here this evening after all. Bex and John, got the right people in the room. Okay, thanks very much, Hannah. I think I hand over to Dawn now. Dawn, let me know if you don't have control of the slides.
So you're going to share, that's it, fabulous. You need to change the view because it's gone on to notes view.
Do that the last time, sorry, 2 seconds, I'm doing it now. That it?
Yep,
No.
let's see. Let's close the chat so I can see. Yes, and it works. Good. Welcome everybody. So I'm going to do the maximum 10-minute update on the falls prevention evidence and policy. And if you've got any questions from this, I would suggest you put them in the chat box and we'll pick them up at the end. But essentially the plan of attack, if I can get it to, oops, went too fast. You're right about taking your time. I appreciate we are likely to have people on the call from all 4 nations, but what we thought we'd start off with is just some key parts. Hello, key parts in the long-term plan of the NHS, and that's a reminder that falls prevention schemes, including exercise classes and strength and balance training, can significantly reduce the likelihood of falls. And we know that if we worked on falls and fracture prevention effectively, a 50% improvement in delivery of evidence-based care could deliver 100 million in savings. So NHS long-term plan is on board that we need to be delivering things with effectiveness. I might have to get you to, no, we've done it. Okay, so cost return on investment. A reminder that we have an awful lot of evidence base now on effective interventions that we know are fairly costly to put into place, but the benefit back is better than the cost to deliver. So we know Otago is cost effective, we know FaME is cost effective, and in terms of primary prevention, we know Tai Chi is also effective. These have been costed with a view to the evidence base behind them, which is basically roughly a dose of 50 hours, 6 months delivery or involvement at least 6 months, and 3 times a week doing the exercise sessions. So those cost effectiveness tools are there specifically because they're costed for them to be delivered for that long. The issue is, of course, that most of the time they're not delivered in one service for that long. So what we need to be thinking about is to make sure that a person is seamlessly through those services. We had only last week the final publication of the World Guidelines. I'm not going to spend a lot of time on this because this is very similar to what essentially we originally had in the UK anyway as a potential guideline. But what we do know is that if somebody has fallen in the past 12 months, they get looked at in a variety of ways, but mostly to look about fall severity. So if they've had an injury as a result of that fall, they're a frequent faller, they're frail, or they are found that they can't get up off the floor, so they're found lying on the floor, or potential loss of consciousness, then you need to have a look essentially at a multifactorial intervention, and we need to look at gait and balance. And you'll notice that if their gait and balance is relatively good, then potentially we can just tell them to be more active. If they're intermediate risk, then we need tailored exercise. And if they're at high risk, then we need tailored exercise. So it's nothing new there, to be honest, or it shouldn't be to you. Just a slightly easier version for you to see. You'll notice they recommend 2 specific investigations into gait and balance. Of course, you can do many more, and many of you will be doing many more. I suppose the reminder here is this is a world guideline, and there are only a few countries so far in the world that have full services. So the whole point here is to introduce a guideline that all the countries around the world can use and will be able to implement relatively easily. Okay, so moving on to the actual recommendation on exercise. So in this world guideline, the evidence has been updated, Sherrington Review, etc., on falls exercise programs. And you'll notice that they recommend that the exercise is balance challenging, functional, so that includes sit to stand and stepping, with sessions 3 times or more a week. Now that could be group or home-based or mix. And they need to be individualized, progressed in intensity, and for at least 12 weeks, but continued longer for greater effect. So they recommend, where feasible, also the inclusion of Tai Chi and progressive resistance strength training. Again, there's really nothing new here, or it shouldn't be, for those of you that are in this world of exercise and falls prevention. They're just following on from the original Cochrane Review, and this is a reminder of the original Cochrane Review. The rates haven't changed much in the update, it has to be said, but we know that exercise reduces falls by about 23%, reduces the number of people experiencing 1 or more falls by around about 15%, irrespective if they're high or low risk. That's an important point to make, but of course it depends on the intervention they're offered. It may reduce fall-related fractures, may reduce falls requiring medical attention, and exercise is the most effective single intervention in any multifactorial program. So not suggesting you don't do other interventions, but don't miss out the exercise bit. That's the key bit, and I'll return to that point in a little while. But this evidence summary really doesn't capture the detail and the devil that's in that detail. So one thing we know is that if you sub-analyze all of the 108 randomized controlled trials that were in that review, if you look specifically at the ones which are considering balance and function, we know there's a reduction of around about 24%. But if you look at multiple types where they introduce resistance exercise and progressive strength training as well, you'll see that the rate actually increases. What we also know is there are multiple programs out there. And in fact, in those 108 randomized controlled trials, 40 of them were not effective. So they didn't reduce falls. They were written and designed by therapists and researchers who thought they were delivering an intervention that would reduce falls, but they didn't. And that's an important point. I'm going to come back to that in a minute as well. We know that if the intervention is purely about strength training, it doesn't reduce falls. If it's dance or it's just walking, it doesn't reduce falls. A couple of studies have shown it, but most haven't. So the point again is that it's not every type of exercise reduces falls. And I think the really important thing, and I'm not expecting you to be able to read the detail in this slide, this is a forest plot. These are what the outputs of the systematic review when they're doing a meta-analysis. And just to try and orientate you a little bit with the slide, hopefully you can see my mouse, each of these are individual studies. And you'll see there's a central line and a little bar with a dot and 2 lines. Anything that's to the left of that central line is an effective study that reduced falls. Anything that's to the right, so for example, this one down here on the bottom right, is where it actually may have increased falls. And anything that's crossing that line, it's not a significant effect. So some people reduced, some people didn't. And each of these arrows are studies which did not reduce falls. They did improve strength and balance. They improved proxy markers, but they didn't reduce falls. And this is a really key point. We can see what we think is effect because we see their strength or their balance improving, but it's actually not so easy to go on and prevent falls. There's a whole variety of reasons why they may not have prevented falls. It could be that they're too short in dose or duration. It could be that there's not enough standing work. There's all sorts of reasons, but the point I'm coming back to is that don't get hoodwinked into believing you've prevented falls because you've seen a short-term improvement in strength and balance. So the fidelity matters. If we've got programs that we do know work, we need to make sure we follow them. And the type of exercise, the components of fitness, the frequency, the duration, the behavior change support, because any exercise program is only as good as the people that do it. And therefore we need to change behavior to do that. And that involves an understanding of why they're doing it and why they're doing it for so long. So we call that physical literacy, an understanding of that. So in an ideal world, we want to follow programs with fidelity if they exist and we can use them. And the 2 programs that we're going to spend a bit more time talking about today, because they've been highlighted as cost effective to run in the UK, they're both based on fundamental principles of training. They're specific. So the exercise is specific to the point of the actual program. In other words, improving balance and strength. They have overload. That means there is a greater than the normal stress or load on the body. You won't get an adaptation without that, a physiological adaptation. And they're progressive. So there is a gradual and systematic increase in the stress that's placed on the body so that you get a continual training effect over time. But the really key thing is the thing in orange. Effects stop when the program is discontinued. So if they go back to sitting because they've been signed off from the program, then essentially you will see a big reduction over time. Is everybody else having problems with their screen, or is it just Kath? Just put it into the chat if you in case that's me. Right, so what does work best? We know functional strength and balance 3 times a week. We want people to be exercising for at least a total of 2 hours in a week. So that's quite a lot of time. So coming along to once a week class is not going to cut it. We need a decent duration and we need a dose of around about 50 hours. So really important points. I hope that we've just sort of reminded you. But I'm also aware that many services are seeing frail people, people with sarcopenia, and of course, both frailty and sarcopenia are strongly associated with falls risk. And if you look at the number of systematic reviews where the outcome is frailty or sarcopenia, guess what? want a duration of more than 6 months. We want sessions lasting each an hour, 3 times a week, and we want it multi-component. So we're back again to, this is not a quick fix. And to be honest, the frailer they are, we can see changes really quickly, but we do need to make sure we engage them for long enough that there is a physiological change that brings them above a threshold for dependence or independence. And as I said before, if you don't do it, then it's not going to work. And therefore, just handing somebody some exercises to do at home, the chances are they won't do them. Or if they do them, they won't do them to the level we want them to do them. And so the real important part of this would be an understanding and education of what it should feel like, what they should feel like at the end of a set, how they should feel in terms of wobbliness when they're doing balance work, goal setting, short-term goals. And that might be as simple as, I'm going to make sure I do 10 minutes each day because I'm not very good at doing it in 3 half-hour slots. Highlighting successes. And of course, if they are in groups, you get a lot of that support from peers as well, from other people in the group. And it can be best supported over time by trained instructors, especially if they're coming into groups. People are coming into groups because, of course, they're seeing them on a weekly basis for a long period. So we can see some real change happening. I'm going to just talk to you a little bit about some pragmatic delivery and where cutting corners sadly doesn't work. So we know Otago works. I'm going to talk a little bit more about Otago in a minute, a specific program to prevent falls. And in the pre-fit study, but also a PROACT study, so 2 big studies with nearly 4,500 people in them, found that if you shorten the Otago dose and you don't progress the ankle weights, for example, you don't focus on the walking program, you have less physical contact and support phone calls with the individuals, that there's really no change in falls risk. So we saw in pre-fit that at 4 to 8 months was a very small decrease in falls rate, which completely disappeared by 12 months, which suggests they weren't continuing that progressive overload, or they'd actually stopped. And interestingly, in the multifactorial groups of these studies, only 40% of them were offered exercise, and yet it's the biggest risk factor for falls. So there's something going a bit wrong with our systems if we're not automatically offering the biggest reason for falls is gait and balance issues, if we're not offering that as a potential. So I realise that for many services, they don't have necessarily time to spend with somebody for a year or for 6 months or for even 3 months sometimes. So we need to perhaps reframe how we work with these individuals. And part of that will be use of these referral forms and working more closely with your exercise colleagues out with the NHS. So just a little reminder of the things which unfortunately we quite often see in real life. They might well be just given the Super 6 exercises to do. There's no evidence that they reduce falls. There are a multiple number of dance programs appearing out there which are calling themselves falls prevention. We don't know if they reduce falls. Just sending someone to be more active won't necessarily reduce the falls. Seated exercise won't, and just telling people to walk more won't either. It needs to be that multi-component form of exercise that builds on their specific needs. So it has to be individualized. Okay, a little bit of a thought about what happens if you do have them in your service and they do some exercise, you see some nice improvements, and then you discharge them. And the chances are, as I said, they will just stop doing things. And just a reminder that if people stop and sit, they will become frail, even if they weren't frail already. So frailty can be a one-way direction if they are inactive. And we know that older adults are rather prone to sitting for long periods, and they may well do their exercise program and sit the rest of the day. That's called compensation. So we have to be thinking about that frailty level. Just aware of time. So what I'd like to do is just remind you of a couple of things. If you were dealing with a cancer patient and you knew the effective dose of chemotherapy was a particular dose, you wouldn't give half. you would give them the required treatment. So think about exercise to prevent falls as a treatment rather than a supplement, because we do need for each individual for them to achieve a decent dose that has a chance of keeping them upright if they trip. This was something that I was chatting through with Sarah the other day and suddenly thought, you know, maybe we need to make it a little bit clearer. We're going to go into a bit more depth about the Otago program in a minute. The Otago program was designed as a home-based program that people essentially did on their own with support from a therapy team or a trained nurse. They actually were seen 6 to 8 times across a year and had phone calls in between, and they reduced falls. So if you've only got 6 to 8 contacts with somebody, maybe don't do the 6 to 8 contacts all in, you know, a couple of months. Maybe space it out over a year, but ensure that you are doing that progression in between. So reproduce Otago as it was originally developed. Think about seeking out evidence-based options to transition your patient onto if you can't keep them with you for a length of time, or if they haven't improved to the level that you think will make a difference to their independent living and falls risk. But also really spend the time, you've got 6 to 8 contacts, really spend the time educating them about the importance of why they need to feel wobbly, why they need to feel the muscles very warm and tense at the end of the strength training, for example. If we can support their behavior change, they're more likely to move into some form of self-management, which therefore will make a difference. So moving on, I wanted just to talk to you about some indications for different evidence-based programs that are out there, and other programs which are not evidence-based, which are out there, because there is always a place, the right program for the right person at the right time. Everyone is different, and I know that most of you on the call are therapists, so you're more likely to see people more up the far right of this slide, frailer, perhaps more multi-morbid, having lots more issues with health. But essentially, the person more to the left might still come to a full service. They might not require your input, and they potentially could be fast-tracked straight on to something else that would still challenge their balance safely and effectively. Not all physical activity programs improve strength and balance, let alone not all strength and balance programs reduce falls. Appreciate again that many therapists on the call won't have many people doing these sorts of activities, but people do get very stuck on one activity, and quite often they might be really quite fit in terms of stamina, but their balance and their flexibility and their strength's poor. So we do need to be sometimes still thinking about the fitter end of the market, if you like. But you'll see that some of those activities that you might normally get in community leisure services or sports activities don't necessarily work on strength and balance either. And I really want to highlight walking. Walking is the most common form of activity by older adults, and it's certainly something they're comfortable with. But of course, all the walking routes out there for older people have been risk assessed within an inch of their lives. There's no balance challenge or risk anywhere. So they're not going to improve balance doing that. They're not going to improve strength unless you get them to walk uphill with a backpack on. And you need to increase the backpack weight over time. So walking is a normal activity the body is used to doing. What we need to do is to make sure we make it slightly more challenging. Where we increase and add walking programs to falls prevention is where people have stopped doing it, and we need to get that movement back into there. So in that whole list, the only thing that's actually got any evidence base for preventing falls as a primary prevention is Tai Chi. So Tai Chi would be great, and for some people that is a great place to send them off to. But if they're frail enough that they need to hold on to something when they're standing, particularly if they're going to weight shift, then Tai Chi isn't for them, because as soon as you have to stay static or sit to do your Tai Chi, it doesn't reduce falls. So again, a reminder that not all activity improves strength and balance, not all strength and balance activity reduces falls. So I'm going to talk a little bit more now about FaME and Otago and explain a little bit about the differences as well. And just a reminder, these are not new. In fact, they've been around a very long time. There's a history to both of these programs being recommended in the UK. It started with the Department of Health Prevention Package back in 2009. Physiotherapy Works, so they've done a number of documents on this, and there's a case study on FaME, for example, in the 2011 Physiotherapy Works document. Age UK have got an evidence-based expert series, again, case studies on FaME and Otago out there in the community. We had an audit by the Royal College of Physicians looking at older people's experiences of Otago and FaME and other exercise programs in falls prevention. And in terms of more recent input to try, this is more Public Health England attempting to get people to follow some evidence base. We've got a consensus statement, again, talking about Otago and FaME, and a huge suite of return on investment documents and spreadsheets to support commissioning. Wales also have a specific focus on Otago and FaME within their programmes, and even the Royal Osteoporosis Society. I can put references for anything on these afterwards on the AGILE website. So here are the two main programmes. Going to spend a little bit of time explaining the difference. So Otago, I mentioned this a couple of times, and I've talked about the big studies that have used this. This was originally developed to be delivered by physiotherapists. It was home-based over a year. It was 3 times, people were asked to do half an hour, 3 times a week of structured exercise, plus a graded walking program. It's very prescriptive. So it's a set of exercises which you progress through. You don't do all of them at once. You progress through as you need to. The important part is there was at least 6 home visits to discuss any barriers, to check technique, to check ability, and to progress people on. And then monthly phone calls in between those visits to make sure that they were doing them and still reminding them to do them. There's also been a fair amount of research more recently on group-based delivery of Otago. And on the right in blue are the key things that have been shown in these multiple, in fact, there's been 22 studies so far that I found, which have looked at Otago as a delivery mechanism for falls. So it reduces falls, it reduces injuries, it improves physical function and quality of life. It's cost neutral in the over 65s. What that means is that it costs you just as much to deliver as the return on investment that comes back, but it's cost effective in the over 80s. In other words, we see more effect in the older adults doing the Otago. And then there's FaME, Falls Management Exercise Programme. This originally was developed for frequent fallers. So the people that were in that were frequent fallers of over the age of 65. It's a 9-month programme, and it was a group-based programme. So they met once a week in a group, and twice a week they were expected to do some home exercise. And of course, each week they were prompted to do that. Standing strength and balance programme. It differs from Otago. I'll come into a bit more depth about that. Oh, Edie, I can see your comment there. I'll come back to that in a minute. Is key in FaME because we wanted to regain the ability to get up off the floor if they'd fallen. But it's also more recently had a big evidence base in sedentary older adults who may have fallen but are certainly avoiding activity. And we've seen over a 2-year follow-up a big reduction in falls in them as well. Edie's just asked me to talk about the cognitive function. The Otago programme, one of the studies has looked at executive function. That's the planning of movement in particular, and the sort of programming of how you would work your way through an environment, that planning aspect of cognition. And in groups, when it was delivered in groups, there was an improvement in executive function. So it would suggest they might be better at dual tasking after they've completed the exercise programme. It's not been looked at in FaME, but actually a number of other studies more recently have started looking at balance programmes in particular, and they all seem to have a positive effect on executive function. So that's pretty good news. This is very small print, and appreciate you may not all be able to read this, but we will be including the references and the slides to anybody that wants to look at this afterwards. These are the improvements in things other than falls with FaME and Otago. Because they're not just preventing falls, they have a lot of input into other things. So essentially you've got habitual physical activity. We know that muscle power, bone density is maintained, fear of falling is reduced, improved confidence, risk of death, ability to stop yourself moving into care. All of these other things are important. Okay. Here's give you an idea of the sort of rates of falls reduction. So Otago, depending on which study you look at, which also depends on which population group you look at in terms of age and duration of delivery, we're looking at between 18 and 45% reduction in falls rate. So, okay, Nicola wants to know about executive function. Executive function is just a simple way of putting that is, can you walk at the same time as counting backwards? So it's the stops walking when talking. You may have come across that in previous times of talking about falls prevention. And we know the frailer we get, the less we are able to do two things at once. So executive function is your ability to plan on which aspect your brain needs to concentrate on first. If we're walking, then it should concentrate mostly on making sure the walking is still good. But often if we then stop to chat to someone or to answer a question, our walking can be affected. So people with poor executive function are more likely to stop walking to answer a question because their brain can't program and work out which bit to move first while it's also talking and doing something else. So in effect, people with dementia always have poor executive function. And poor executive function potentially is a precursor to dementia later on. Hopefully that's answered your question. Back to Otago. So I've put two specific of the Otago exercises on this slide for a reason. Many of you will be using Otago and will be using some of the exercises in Otago. And I wanted to remind you that if they're leaving your program before they are capable of safely walking backwards or doing a figure of 8, you haven't gotten to the point where they're going to reduce falls. Because falls happen when we transfer, we move, we turn. They happen when we have to take a sudden sideways or backwards step because somebody or something's got in the way. So if we don't have the skill to do that, and we can't do that in an exercise program, we're not going to be able to do it in real life. So if the person has only got to the point where they can do some very static Otago balance exercises, you haven't helped them reduce their falls risk. So just a thought about that. Okay. Excuse me, my phone's buzzing away. I'll try and move it over there. FaME. FaME reduces falls between 26 and 54%. So it's 54% in frequent fallers, it's 26% in sedentary older adults. We know it increases habitual physical activity. Interestingly, up towards the actual physical activity guidelines for health. So they are becoming confident enough in their movement to be active in many other ways, not just in their moving around their own home. A little bit, just looking at the time, so I need to stop fairly shortly. A little bit, just want to pull out a few things here. If you look at the Otago people that were in the studies, just look at the walking aids and care at home, you'll notice they were relatively frail. So 22% were receiving some sort of care package in the first study. In the second and third studies, we're looking at they weren't necessarily preparing their own meals and they had people in to help them clean. So these are the frailer older adults that Otago is appropriate for. And a few studies suggest that if they are more active, that they don't require any form of care support and they're not using walking aids, that perhaps Otago is not at a high enough balance challenge to reduce falls. Here's just some of the pictures of the FaME participants, just to give you an idea of the range. These were taken over a period of 9 months. And if you look at this picture here, believe me, none of them were doing that at the beginning. Absolutely none. We were much more likely to have them sat down, holding onto a chair. Many of them were using Zimmer frames and required transport. But if you have someone with you for long enough, and I just wanted to give you an idea, this lady in the middle is 89. And that was the first time she'd been on the floor, apart from a fall, for many years. She even went out and bought a leotard because she knew we were introducing it. So the important thing here is that if instructors and people have a chance to have people with them for a long time, you can see a step change in their ability to do things. And this is Violet's story. She went from us providing transport to the class. She used a walker, previous hip fracture, very scared. And at the end of 9 months, she wasn't using a walking aid. She was using the bath again. She was coming to us by bus. And she, believe it or not, she asked me where she could get some more hip protectors because she wanted to play tennis again. That's what you can do with someone on an extended, continuous progression of exercise over time. The deliverers have been different. So Otago has the evidence base behind Otago is a whole range of deliverers, as you can see. FaME, actually all the evidence is in exercise instructors delivering that, although we know there are many physios that are trained in FaME. And as you can see, Otago is evidence best for those over 80 with a history of falls, and that FaME, it would cover both frailer and less frail. Also a reminder that Otago is a strength and balance program, whereas FaME is multi-component. So it does bring in endurance work. It does bring in backward chaining and floor coping strategies, stretching, and some adapted Tai Chi. The instructors that deliver in the community, your exercise instructors, are also trained differently. So Otago leaders, if they're exercise instructors, should hold a minimum level 2 fitness qualification. They would be working with guidance, either from a physiotherapist or a postural stability instructor in terms of that first level of prescription. And then they can progress people from there, but just to be sure they're starting on the right level. And their training focus is much more about group management skills, although Bex may get around to talking a little bit about this later, possibly if we've got time, but we are looking at, in fact, we've just launched the first pilot of a rollout of Otago in NHS settings to therapy assistants, and it'll be very much about one-to-one focus and behaviour change as well. FaME is quite different. Here they should hold a minimum of level 3 fitness qualification. FaME is actually at the level of a university module in terms of number of hours and the sort of content they have to cover. The training focuses on group management skills, but they also are taught to tailor, to assess, to tailor and progress exercise with frailer older adults. And they often also hold multiple other qualifications, including Otago leader qualifications. So I guess I just want to leave you with a couple of simple points. A generic older person's exercise session won't cut it. If you haven't got that progression of challenge for strength and balance, you're unlikely to reduce falls over time. And importantly, yes, exercise could be considered complex, but actually it's the people that are, and it's mostly their behavior change needs and their support needs. And we know that exercise instructors can do a great job with that once they've left the therapy setting. So just think about the fact that if we send someone on to an appropriately trained instructor, they will be able to progress the gains that have been made in therapy. Supervision is important, so please don't just send people off to do a home exercise program if they are very frail, because what we do know is that in both Otago and FaME, those people who are very frail weren't in the studies because they require one-to-one supervision or therapy. And for example, Kathy Sherrington herself did a study where she people were discharged from hospital, were given a home program with some home visits. And although we increased mobility, there was also an increase in falls. So we need to be pretty careful with people also with specific disease like Parkinson's. So a reminder that across the transition, in terms of the workforce in the community, there are different levels and scopes of practice, and Bex again may well touch on this a bit later on. If a person is a faller, then we should be sending them back into the community to a falls prevention programme, which has an evidence base, because then we've got more chance of seeing change. There are plenty of really good service evaluations, and again, aware of time, I'm not going to spend any time on these, but these are service evaluations of community-led programmes of FaME, good return on investment, good improvements in function and reduction in falls. So that's me for now. There's going to be loads of questions I can see keep popping up in the chat, but I think we might have to leave those to the end, just time-wise.
Thanks very much, Dawn. I appreciate it. Yeah, let's keep the questions to the end. I can cut my resource share section right back. Have I still got the same slide share view on my screen? Because it's different to what I started with. So just checking that you haven't got the presenter view. So just wanted to have a think about, based on the evidence base and the share that Dawn's just walked us through, what's the current state of play when referring from physiotherapy-led NHS exercise programs to exercise instructors in the community to support the longer-term exercise participation that we now know is essential in order to achieve the positive outcomes? Just got a couple of Menti questions just to take you through. So asking the physiotherapist in the room, what's your current practice to support longer term exercise post-discharge? So if you log on to Menti again and use the code on the screen, 3735006, there's 5 options there. So you refer to evidence-based exercise programs already by an agreed pathway with an agreed referral form, or you recommend people to evidence-based exercise programs that you know are provided in the community, and this is a verbal recommendation or a list that you give to the individual on discharging from your service, but you don't necessarily refer or share information with that community provider. You give them a list of exercise and physical activity opportunities that might exist in the locality, or you might give them a home exercise program for them to do at home, or none of the above. How are we looking, Hannah?
Yeah, they're still coming in. I think we're probably getting close to the number of physios we've got. So let me just let me share it with what we've got now, and then it's taking its time. There we go. So pretty evenly split between the referring and providing a selection of exercises people keep doing at home.
Okay. Be interesting to find out in the chat whether that exercise that they can do at home is supported with follow-up by telephone calls or any further progression. If you just add that in the chat, that would be interesting. Or is this for them to do in a self-directed manner at the time of discharge? Okay, moving on to the next Menti question.
Yeah, so you need to share again.
Yeah. Delay just a second. Okay, so exercise, have you got a view? Thumbs up. Exercise professionals in the room, all 10 of you. Do you get referrals into your sessions? So again, Menti 25849584, 4 options there. You do get referrals from therapy services, and it's an agreed pathway with an agreed referral form. You get recommendations from therapy services. This is a verbal recommendation, or the service user coming to you has been given a list, but no information is transferred between the therapist and yourself. You get referrals, but they come from local GPs, or you don't get any referrals at all. People tend to self-present.
There are a lot of comments in the chat about how people don't have the capacity to do any follow-up. They just can't. They just can't do that. There's quite a few similar comments there.
Beyond
and Sarah,
discharge.
and you're back in your presenter mode again. Sarah, you might want to flick it back.
Okay, so let me share that again. There we go. So again, pretty even split between getting referrals or recommendations. On that.
Okay. The numbers are small, but it's nice to see
Yeah,
that
I think we put it
referrals
at
are
6
coming through, and some
Yeah, 15 people.
Yeah.
I know,
Yeah.
so
and good that GPs are referring. We go again. Bear with. Am I in the right screen, Sarah? No. Keeps every time I open it up again, it flips back, but my screens are the wrong way around, so I think it's right. Is that right?
No, go back.
Just it's the same thing on.
Don't worry, so honestly, it's a good view. We can still see everything.
yeah, it's still clear. So.
Yeah. I'm not cheating anyway. Exercise professionals, what are your current referral options? So a new question in Menti, new code,
Yeah, new code.
54351920. So can you refer formally or informally back into therapy services if you think that they actually need a multifactorial falls risk assessment, or they're not improving in terms of their falls risk with the exercise prescription that you're offering? Or can you recommend clients go back to their GP to get referred back in so they can access clinician-led fall services?
Comments come in just to say very few referrals from physios in Cornwall. We are asking for self-referrals due to data sharing and cyber security. And someone else has said there are very few groups in my area onto which I can refer. Mostly recommendations, but very few are via an agreed pathway.
Okay.
Okay.
So
I think that's everybody. So see, the majority are recommending rather than having the ability to refer back.
Yep. Okay. Got the right view?
Yep.
Yeah.
So I think what we anticipated was on a level what's come back through the Menti question. So currently few people are referred into evidence-based falls prevention programs in the community that are delivered by trained instructors, which means that those people that aren't being referred on and who aren't achieving the dose in NHS services aren't actually reaching the necessary dose and progression that they need to reduce their falls risk over time. And that potentially raises the risk those individuals would come back into services either with an increasing falls risk presentation or a recurrent fall. I think we're probably getting a sense from the feedback that people attending the evidence-based falls prevention exercises in the community are not so much coming from community that are from NHS-led therapy settings, but much more self-referral and or GP-led, unless they've got established exercise pathways out there already, which I don't think are the common, they're not the norm. Although there are good examples out there, and I'd be keen to learn more from those in the room who actually can talk to that. But that also means, therefore, if the people aren't referring mutually in both directions. It means it isn't easy for those people who are going straight into the community exercise classes to access multifactorial falls risk assessment if they needed it, particularly if the exercise professionals aren't readily able to refer back in, and the time that it takes to go back to the GP and be referred back in and go through the waiting list is likely going to cause distress, if not, not offer a timely intervention. So we are still working in silos, it seems, even though we're involved in delivering evidence-based exercise for the same, condition, if you like. If the falls is not necessarily recognised as long-term illness, but it's definitely a syndrome that we all encounter every day in our practice. And I think therefore we need to work harder, more partnership, in order to deliver a more seamless exercise service for those people who are at risk. I think now I hand over to Bex. Yeah, he's going to talk us through the rationale for the sharing of high quality information for individuals as they move across the falls pathway.
Quick set from me, I think, folks. And it seems from all of the comments that, as Dawn said, we are speaking to the converted. So perhaps these next few slides from me, maybe the call to action is slightly different, and that is in discussing these things with your colleagues who perhaps aren't on this call and who are perhaps not as bought in as you are. The key thing about the referral forms, they are sharing information. They're passing on valid information to support lots of things to then happen, achieving this longer durations in training. It is everything about achieving exercise dose. So the referral forms are designed first and foremost to support the training journey. And I think a key message I want to make is that a referral form isn't just about suitability. It's not just saying this person is suitable. And actually, if that referral form is coming from a GP, I'm going to say maybe it might not be. I'd be keen to know exactly what information you're getting from GPs. Not saying it's bad, not saying it's insignificant. GPs are on board, that's good. But what can they tell us? What can they tell us? So these referral forms that we've been working with in collaboration with AGILE are really about referrals from physiotherapists who have information, have captured what's happened with progress so that we can get people off and continue people on their journey. So it's not just about suitability. It's very much about passing on information about what's happened. That passing on the referral process is not just about in context of whether this is Otago or whether it's FaME. It's what environments are these programs going to take place in. We have lots of questions about supervision requirements. How many people can we have in a session, in a class, in a space? Who needs one-to-one? Who needs a group? So understanding how people have performed within their therapy setting, if you like, is captures all that information that I as a PSI need to know to translate into our environments. So we want to know how they cope with balance challenges in one-to-one settings. Did they use parallel bars? Were they on walls? Were they on fixed firm surfaces? This is the stuff that we need to know, because when we move into community venues, to dusty church halls, with inadequate floors and chairs and surfaces, everything changes. So we need to know as much information as we can. The baseline exercise selection, as Dawn has said, for Otago, that really should come from a physiotherapist or an appropriately qualified person to help and support OEP leaders with their baseline exercise selection, so that we're not just starting at that easy level. We want to literally hit the ground running to continue this training journey, not just start it and start again. Many of these people don't have that time to waste. We need gains now, and we're wasting so much time on insufficiently dosed stuff and stop-start journeys across this pathway. So there's so much information in the long form. If they have been with you and they've been, attending programs with you and doing the home exercise programs or not. We need to know this stuff because it hugely supports getting people off to a good start. And we know that is at the heart of actually of successful support across a journey of behavior change. Progressions and tailoring are in there again. The message is the same. Stop the stop-start and let's help progress and continue the journey. So scope of practice is wrapped around this as well. So we may receive referral forms that on reading, we, the exercise professional, may go, actually, I think I'm out of scope. I think I need to go back. I think I need to have a conversation with this referrer, with this physiotherapist. Just because we receive the form, PSIs and OEP leaders out there, doesn't necessarily mean that they're right for us. We know if we're right for us. So we should be able to pick up that phone and have that conversation, ideally. Next slide. I've lost me widget to move it on. Thank you. So we need these people to be appropriately trained for the people that we're working with. It's stuff that Dawn's said before already. We want a standardized form. We know the information that needs to be imparted that then can support us do a better job. And this is all about continuing journeys. The gains come as time progresses. So nothing can really be achieved in those 3, 4, 5 sessions. Thank you. Next one. These next 2 slides, I mean, if you're already bought into this, what we're saying, maybe you can, ideas about what you think these pictures mean. And I'm just looking for quick, simple messages that you can take back to your workplace and your colleagues, so that when people say to you, what was the webinar last night about referral forms? You go, right, okay, a referral form does this. It enables us exercise professionals, who are really arguably the only profession that can help people achieve these durations. We don't want to get off to a tortoise start. We can get off to a hare start. We can get people off to best starts and hit the target sooner. We can do a whole job, not half a job, if we can get exercise selection and progressions right at the beginning. That is going to prevent reversibility, i.e. a decline from after the progress we've made. We're also going to hopefully avoid people returning at your doors. And these early sessions are all about the growth, the building, the building of the physical literacy, supporting home exercise programs, so that we can best support this, this change over time. Next slide, please. Currently, and from the chat as well, and from all of our insights and what we know, unfortunately, our systems, our pathways, our fragmented pathways, set up, stop. We end one bit. There are so many dropouts that we create. Conversations can greatly shift and change that. Even if nothing else, even at point of discharge, let's not talk about stop. Let's not talk about you've finished this treatment now. Even if you know there's no appropriately trained PSI or OP leader in your area, it still can't be about stop. More investment in conversations, understanding how they're performing their home exercise programs, because we ourselves are quite often causing the roadblocks. It's not okay to suggest they can go anywhere if they want to. We want people to have choices, of course we do, but we also need to give them informed choices. If you go to this session here on this list that I'm giving you, you're going to get this, this, and this. This is what you've achieved with us. This is what you've achieved with me. This is what we're looking for you to continue this recovery journey. So build the bridges. That might just be conversations. That might not be somewhere where they can go to. Conversations can go a long, long, long way into supporting, helping people understand, really understand what they're doing with this program. Thank you. Next. Right exercise program, right person, right time for them. This is the mantra that came out of the Center for Aging Better report, which is coming in the next slide. Choice, preferences, attitudes, belief, all impact on longevity of exercise programs. We need to find these things out. People aren't just going to take a list of exercises and do it. So are they motivated to do this at home? What's it going to take to do that? Remember, Dawn said Otago is a home exercise program. The evidence, the mother of all strength and balance falls prevention evidence, is there in an unsupervised home exercise program. It's been done. That's the evidence. And yet, not everyone wants to exercise at home. Some people want to exercise in a group. Hence, FaME is designed as a community program. We need to know what their medical conditions are. Are they fearful of falling? Have they had long lives? All of these things will impact on the best exercise opportunity for them to continue with. We know that many PSIs and OEP leaders are working with self-referrals. That doesn't change what we need to find out. That doesn't change how information informs how we set people off to the best possible start. And it's really critical that we build these links, because not every older person out there at risk of falls or fearful of falling will be right for us. We're missing out on all of the other, the multifactorial approach to falls prevention. Strength and balance isn't the only answer. So building links with physiotherapy services is absolutely critical in order to reach everyone at the right time for them. Next slide, please. We've got two referral forms, a long and a short. The fundamental reason for that is, Dawn has mentioned, and I mentioned just a moment ago, not everyone will require input from a physiotherapist or a therapy team. And if that's identified, that's what the short form is for. It's almost like a fast track. The full form, the full referral form, has all of the information. And just to say, this has been a long piece of work to and froing with physiotherapy colleagues in AGILE and within our LLT team as well. This has been designed by physiotherapists, of which many think the long form is the only one we should have. But we developed the short for those that made the point, actually, not everyone needs us. We need a fast track option. So that's why there's two. Thank you. Next slide. I've mentioned this feedback so far a few slides ago, and it's great to see that actually in the Menti, where you did the word cloud, we didn't get a sense of this. And I wonder if this is the feedback that's come from the people that aren't in the call tonight. I don't know. This is the feedback we've had so far. We don't refer, we're not allowed to. We hear this a lot, and we're really keen to get to the bottom of this. We're not allowed to. I notice data protection and information sharing's come up in the chat. I'm going to use the analogy: cardiac rehab, refer; pulmonary rehab, refer; can rehab, refer; referral is happening; information transfer is happening in other clinical exercise pathways. Can we find out how that's happening and why it can't happen in falls? A real difference of opinion. It looks good. It's what we need. It's too long. Even the short form is too long. We don't need a referral form. People refer themselves. Yeah, some can, but actually we want to reach more people. Next slide, please. So what does this initial feedback tell us? And actually thrilled to see that the referral form feedback in the chat tonight has been extremely positive. I, for one, wasn't expecting this much positivity, but we do know that referral is not fully understood, and we're still teasing out the differences between a referral and a recommendation. A referral form that provides information so that we can make decisions, rather than a referral perhaps from a GP that provides a name and address and says this person is unsteady on their feet. It's great, but it's not really what we want in order to do the best job we can to get people off to the best start, to keep them on the journey for longer. So varied experiences and thoughts about what's needed within a referral form, and maybe confusing, inaccurate information about what is allowed would be another conversation to have. Thank you. Next slide. I'm going to pause there. Are there any questions at this point, Dawn? Do you want to interject with anything, or shall I keep going with the barriers?
I think carry on moving. There's lots of questions, but I think
Keep moving.
Yeah.
Okay. I'm gonna, the stuff on the left you can read. I'm just going to switch you to the eyes right, everyone. Everyone loves evidence-based till the evidence is contrary to what they want to do. And it's really difficult not to make this a depressing tale of we're not doing good enough. Everyone is doing what we can. Everyone goes to work to do a good job, and we keep doing what we're doing until we know better. And when we can do better, we've got to keep banging the drum. That's all that we know this stuff on the left, and we can and identify how we're doing within services. And I think it's just, if nothing else, let's just acknowledge what we have and not call it something else. Don't say you have FaME if it's FaME-ish. Don't say we have Otago if it's bits of Otago. Let's just go, right, this is what we're doing. This is all we can do, but don't call it something it isn't. We're doing bits of this and bits of that. And certainly from an exercise perspective, if commissioners already think and hear they have FaME or Otago, and they're not aware that it's been diluted or corners have been cut, then where do we go with that? They think they've got something that they haven't got. Thank you. Next slide. So as a mentee, over to Hannah, I think, for more mentees.
Thank you, Bex.
Time-wise, maybe we haven't got time.
Yeah, I think this is on the back of expecting a different response to the earlier one, wasn't it, really? And I think if people do have barriers to using the referral forms on the basis that you want to use it, but you feel you'll encounter barriers locally, please put those into the chat for us so we can help think about helping you overcome those as we go forward.
If people fill it in the Menti anyway, we can look at it outside of this as well, and share. I can share that with the group rather than having to share it with the screen.
Thank you. Handing back to you again, Bex.
Okay, another short set from me. Okay, just a little bit about us here. So we're a not-for-profit. We've trained loads of people. We've trained thousands of people over the years, and in response to one of the questions, several questions that have come up in the chat about how do you find us, how do you find PSIs and OP leaders, we're still working on ways to help and make that happen, and we've got some suggestions later in the chat here. So we are out there, and we can be exercise professionals or physiotherapists or occupational therapists or nurses or rehab assistants or falls techs, all those things. And LLT are the only training provider for these two exercise programs. Next slide, please. Just 3 slides to come of really better practice. We know it's hard to do, but people are doing it. So the next 3 slides, we have examples from, let me just get my notes here. I think it's Oldham, Rotherham and Cambridge are doing a great job with FaME and Otago, joined up pathways. I know Simon, Hannah's on the call here from Cambridge, and Simon and I, along with the LLT team, work really closely together. And the new format, one-to-one OEP leader training that Dawn mentioned just now, kind of includes all the insights and lessons from the Cambridge Falls pathway, which I do believe, Simon, is 20 years in the making. It's not a quick fix, you know, joining dots and having the right conversations at the right time takes time, and it takes the will and the intention for that to happen. So yeah, keep banging the drum was with one of my icons in the previous slide. So move on. What else can I say? Next one. Dawn, chip in on this one if you feel you can. NFIT is the National Falls FaME implementation team, and is part of it's kind of a sideline to a piece of research happening at the moment called Flexi. The National FaME implementation team comprise the list of organisations on the slide here, and we are offering our support. That's kind of a community of practice, ways that we can support your implementation, and there is a kind of a request form available if you want to fill that out and send that in to us. And two key areas where Flexi will be unrolling is Devon and Manchester. So we hope to have some more implementation success stories following this piece of work. Next slide, please. That is indeed the inquiry form that I've just mentioned. Now, the letter to the left is a letter that we have written to that our PSIs can access.
Sarah, could you just move the slide forward so that, because we've got another picture which comes up while while Bex is talking about that. That's it.
There you go. So this letter has been written to support the PSIs who train with us to better link and communicate and have accurate messages and consistent messages with the referrers about FaME. And I just want to kind of cast your eye down to the second paragraph here that we've flagged up, is that the CSP, the Chartered Society of Physiotherapists, do acknowledge us exercise professionals out there. I know there's only 10 on the call, but there is more of us. So, you know, there is huge support for this partnership, but, you know, for partnerships to work, there needs to be intention and time to make those partnerships happen, those trusted relationships that we've mentioned. And the referral form does that. It does much more than support the outcomes of the older people we work with. If we can build those trusted relationships and work together, have these two-way conversations, we can reach more people. Physiotherapists perhaps can discharge people earlier if they feel confident that they're referring on to credible professionals. It's a win-win for everyone. It might feel like a strong time investment, but once those relationships are built, then everyone understands the scope of practice, and the pathway does indeed reveal itself. Thank you. Next slide. How do you find us? We're still working on this at the moment. Our Facebook or an email to us is what we're asking you to do. If you are having difficulties connecting with physiotherapists or full services in your area, we want to hear about all of this. We'll kind of really want to support after this webinar, a proactive support into helping you find out where we are, and if we realize we're not where you want us to be, how can we support that to happen? So come find us on Facebook or by email. Contact your local activity leads, your local leisure centres, public health, full services, all of these. Just do a search in your area, falls prevention into a Google search, and if you don't come up with anything there, please do contact us. We are inviting you to contact us. Next slide, please. Are we doing this one? Another mentee?
I think it'd be nice just to get it before and after, but I'm going to let people quickly capture the code, and then I'll move on and run through the resources whilst people are putting their answers in. So just give us the words that you'd use now when you think about using the referral forms in practice. Again, 3 words in Menti. The code's 41300351. If somebody can stick that in the chat so I can move on, that'd be great. And while you're answering,
I've done it.
Thank you. Whilst you're doing that, so we can leave some time for questions at the end, I'll just run through resources that would support you having those conversations that we are, encouraging you to go away from today and have at a local level, be it with commissioners or be it with your colleagues, just to drive up the service improvement. And I think, if anything, irrespective of the resources, this slide deck is your evidence base and your rationale and your case in hand, isn't it really? And do feel free to use that to support the conversations that you'll be having locally. So really quickly, highlighting at a local level the impact of the pandemic on strength and balance, and therefore its impact and the consequences of an increased prevalence of falls. So the expectation is more than 250,000 more falls in 110,000 people, costing 211 million over the next 2.5 years, and that's an underestimate. And that came from Public Health England's report on the impact of the pandemic on older adults. So that's a more rationale why we need to do better and optimize our falls prevention exercise pathways. It highlights recommendations on who we need to target specifically, both for the whole population and for more targeted populations who are most impacted by the restrictions imposed by the pandemic. So thinking specifically about those who had to shield, those with multimorbidity, and those who live in social care settings or from more deprived backgrounds. And from a targeted population perspective, thinking about those who are already presenting with functional loss or on a transition towards a higher severity grade of frailty, or who are actually reporting that they've got a fear of falls as a result of the deconditioning impact of more sedentary behaviour. And thinking very much about the largest reductions in strength and balance in our populations we're seeing in males who were aged over 65 to 74 and females who were aged over 65 to 84. So these are the people that we need to be case finding in our communities and working with through our exercise pathways. With the National Falls Prevention Coordination Group, AGILE, and Dawn, and many others collaborated to develop a suite of resources for public, commissioners and health and care professionals to highlight the impact of the pandemic and to support people to take people on a journey towards reconditioning and improving their strength and balance and reducing their sedentary behaviour. We shared these before, but they're on the BGS website and the link's there for you to access those. There's a significant number of resources that have come from the National Falls Prevention Coordination Group, and they're summarised here. I think Dawn's referenced a few of them previously, thinking about the return on investment tool. Again, links to these papers are here and all pulled into one place. And if you're thinking about a local service level baseline assessment, you've got the quality markers that help you understand your baseline service strength and balance service provision through local audit. Raising the bar, we talked about it earlier on around the themes that if you get it right, you're likely going to get the right care, right time, right person, and get better outcomes for people who are at risk of fall. So that's that paper that we've talked about earlier on today as well. And a bit of hope, I've used all of the evidence base that's come out of the previous reports and the deconditioning resource for commissioners and providers to put a business case in for our local Aging Well programme in our Bradford district and Craven integrated care partnership, and we've actually secured funding for a full scope and role to do exactly what this webinar tonight has highlighted the need to do to reduce the inequity, to improve the pathway and transition from NHS-led falls prevention services to community exercise provision, so we can get that accessible and the right dose for the right person at the right time, irrespective of where they live, and targeting the communities that need it most. I'm happy to share that with anybody after today if they wanted to know more information about how we're going to go about that. And so just to conclude, before some time for questions, this is a call to action and maybe a different one, as Bex has alluded to, that's what on these slides. I think, you know, if you've got people that you need to convert locally or through your networks, the falls prevention networks that you have in your local ICSs, please do share the conversations we've had tonight in the slides and try and bring others on the journey with you to use in the referral forms to support that information sharing at the point of transition. Get to know who your Otago leaders and your post-disability instructors are, and if there aren't any, that's the conversations that you need to have with your local falls leads, whether it be at public health, whether it be your Aging Well commissioners, so that we can work together to develop much more robust pathways and actually build the relationships with those that you do know out there, so that information sharing can happen in a two-way direction, so that people can access the right services at the right time at the right the right professional. And I rushed through that, but I hope you understand. I just wanted to give people time to have some questions. So I'm going to stop sharing and open the room.
The chat's been really busy. There's been lots of really constructive conversation going on. Do we want to do some questions now, or Dawn said she's happy to respond via emails? I have got some of the questions from earlier on in the chat if we want to answer a couple now.
Yeah, and let's answer a couple, I think.
Okay, so we've had one from Sam who said, is Otago or FaME more appropriate for an older, frailer population? Therapy staff running our NHS groups feedback that our attendees struggle with completing Otago as it is designed, but they also feel they wouldn't manage FaME.
Okay, so first of all, Otago, you don't go straight to the walking backwards or figure of 8 turn. We would start on some of the seated strengthening work and this very static balance work to start with. If they're very frail, you have to build up standing stamina, because we need to have them in standing to reduce falls. The FaME is, if I go back to the fact that FaME was originally in people that had 3 or more falls and were using Zimmers. So these were really quite frail people. It's just that if you've got them long enough, you can build them up to standing balance. So I guess Otago is the only evidence-based program for very frail that's out there, and basically you just have to build them up slowly. And if you can't build them up quick enough in your service because they're very frail, then potentially you have to refer them on to somewhere where they can carry on that work.
Suzanne has asked, have you compared cost for the 2 programs for a physio delivering it compared to an exercise professional over 9 or 12 months?
No studies have done that. And in fact, if you look at the Otago studies, there's only one that's actually delivered by physios. All of the rest of them since have been delivered by trained nurses, exercise instructors, technical assistants, and FaME has never been done with physios delivering it at all, I'm afraid. So no is the answer to that. But I'm going to be really honest. Physios get paid a lot more than exercise instructors. So if you put those 2 together, the chances are the exercise instructors would come out cheaper.
One from Paul, are ICSs investing in the 3 times per week exercise session in any part of the UK nations or Northern Ireland?
I'll ask other people on the call, but I don't think so. But what we have to remember is you haven't got to see them 3 times a week face to face. It can be that you support them to do it 3 times a week at home with phone calls, or it could be a once a week class and twice a week at least supported to home. So the dose can be a mix of face to face and home supported.
And Fiona just sends us, how confident do PSIs feel delivering these programs to patients with cancer? Oh, my screen's moved, being cared for palliatively with significant mental health issues?
Bex, I'm going to pass that over to you.
It's a scope of practice issue. I mentioned earlier on receiving a referral form, only I know if I'm in scope to do that. Have I undertaken training in this area? Have I had sufficient information from the referrer? As many of you will know, there is a CAN rehab exercise training course that sits alongside PSI and cardiac rehab and pulmonary and. So when there are other long-term conditions present, other comorbidities and pathologies present, we need to ask ourselves, am I within scope to work with this? And if I do not understand how to work with someone living with any condition I haven't undertaken training in, I need to stop, pause, and go and speak to the referrer. That's what we mean by trusted relationships.
One more question. Yeah.
Oh, I wanted to say something because I think it feels like I want to say it, and it's on the back of a previous question. I put it in the chat here. Sufficiently dosed exercise is relative. So Otago has 22 exercises, and I'm just reinforcing Dawn's point. The aim isn't to deliver 22 exercises today. It never was, it never is. And as soon as we've got past knee bends disappears and we move on to something else. And if we want people to feel positive about completing home exercises, then they need to be the ones that relate to them, relate to what's important, what we can achieve greater successes in the quickest amount of time. So if people aren't tolerant on their legs, Otago isn't for them. Skill them up first. But if they can stand up, there's something something they can do in Otago. It doesn't have to be 22 exercises. That's not what this is about.
And to reinforce that point, if they're very frail, they will tire very quickly. So the home exercise program probably shouldn't be a half an hour, because that might knock them off their legs. We should be perhaps looking at 10 minutes daily rather than a half an hour in one go, for example. And we may only offer them 2 or 3 exercises to do at home, so that we know they're going to complete them. And then as the weeks go on, you can add more as you get buy-in from them. So that's why it helps to have weekly contact, of course, because that means you can do that really guided. As soon as it becomes a once a week or once a month phone call, then you don't have the speed at which you can potentially move people through those.
Steffi, may I answer the question about, there was a question, I think it was Susie, that said, does anyone add floor work to their Otago?
Yeah, please do.
Just to say, it kind of really highlights a key point here, that obviously the FaME program, that whole journey of that FaME training, those 3 phases and that multi-component approach includes upper limb, upper body management of own body weight. Otago doesn't do that. Otago is purely lower limb. So of course, we still want to skill people up to get up from the floor, but if they're not ready for that, if they don't have the range of motion to do that, if they don't have strong enough wrists or range in their arms, then that's not going to be a positive experience. So we know that we want to skill people up to maintain that skill or to learn that skill, but Otago isn't really going to help them do that. It needs some other form of training to do that.
Thank you, Bex.
A good place to stop, doesn't it?
Yeah, I think so. I think there's so many questions in the chat. Sarah, if we can download the chat, then between Bex, Hannah, Steffi, Dawn and I, we can bounce them back between ourselves and put an answer to each of them, or where their themes, group them together, and send them back out with everybody when we're sharing the slides, so that people have got those to go back over and review, in order to kind of let people feel that they haven't asked questions that haven't been answered. So I apologize if you feel like that now, but we will put all of the questions into a Word document and put an answer to each of them and share them back with you. That leaves me just to thank everybody for your time, a little bit over as always. Thanks especially to Bex and Dawn, who without doubt are experts in exercise prescription for older people who are at risk of falls, and I think we've got a lot to learn from them, and I hope you can appreciate the rationale why Agile and Later Life Training are keen to continue to work together to try and support all of us, physios, exercise professionals, and anybody working in falls prevention pathways, to achieve the best we can for those people who are at risk of falls, and do that in the most evidence-based way.
Could I just add something else to that, Sarah? We're not trying to, Bex and I are not trying to knock physios. You guys are buried in a massive load of, especially post-COVID. There's so many people coming your way. What we need to do is fast track people that can come away as quickly as possible, so you can work with the most complex. Been a few points in the chat about a lot of community programs haven't necessarily restarted. They are slow, some of them, but many of them started in the middle of COVID, still happening. So it doesn't necessarily mean that your local area has, use Google, but contact us if you can't, and we'll do our best to.
Dog manager.
Thanks, Dawn. Thank you very much, everybody. You go and have your hot milk, cocoa, something stronger. Nice to see you all.